What is your thought on the number one reason for failure for ultrasound-guided IVs?
Number one is we don't know where our tip is. People cannot and have a hard time identifying their needle tip. For me, how I train and how I practice is if I cannot see the needle tip, I don't advance the catheter because clinically we're trying to measure what was the risk of damaging the patient unintentionally. What was the risk of perforating things we didn't want to perforate? Pulling out the needle is not the problem. It's going forward with it that we can hit things we're not supposed to, or that we unintendedly, like arterial nerve bundles. And so that's one attempt, but nobody wants to measure it that way because it is so difficult. This is why when I measured it that way, I was now more careful about making sure that the trajectory of my needle tip was going the right direction, and I moved slower. Just want to go forward once, and that's it. And that's that difficult acceptance of that definition made me a better inserter because it forced me to make sure I wasn't BSing or bullshitting my needle direction. So that's the number one thing, not knowing where your needle tip is.
But one of the things I have really learned, slow down. Like I get that initial poke just to get over that shock for the patient. And then it is literally, we are finding it. We're advancing, we're finding advancing. And I wouldn't even touch that because I was like, I don't feel comfortable. But as I've gained more experience with that slow approach, if that is my only option, I am much more confident accessing that now because of that going slow approach. And I think that is what, and so when I'm teaching somebody now how to do ultrasound guided, I teach them the slow approach. If you don't know where your catheter tip is, that hyperechoic focal point that you see on your monitor, if you don't know where that is, you might as well blind stick them because that's exactly what you're doing.